Hello. Okay. This is on now. Sorry. All right, everyone. Hope you enjoyed lunch. Want to bring everyone back to get the afternoon sessions going. We're going to start off the afternoon with session 3, high yield topics in therapeutic endoscopy. And our first talk is courtesy of Dr. Kusuma Pokala, one of our former general GI fellows and current all-star advanced GI fellow. And she's giving us the talk updates on screening, surveillance, and management of Barrett's esophagus.
All right, thanks, Blake. So let's just hop in. I have no disclosures. We have a few learning objectives for the talk this afternoon. First is to review risk factors for Barrett's esophagus and esophageal adenocarcinoma. The second, to understand which patients should undergo screening for Barrett's esophagus. To understand the components of a high-quality Barrett's esophagus exam. And to discuss when biopsies should be obtained to evaluate for Barrett's esophagus. And to review principles of endoscopic treatments for Barrett's. So I'd like to frame this talk with a case. We have a 67-year-old white male with a history of tobacco use, class 1 obesity, long-standing GERD symptoms, who is referred by his PCP for an upper endoscopy for new dysphagia. You do his EGD, and this is what you find. Find a mass in the lower third of the esophagus. You perform biopsies, and the diagnosis is esophageal adenocarcinoma. Further workup reveals that he has stage 3 cancer and will require surgery and chemoradiation. Cancers like this are preventable if we can identify and screen at-risk individuals and manage them appropriately. Today, I'll focus on the updated American College of Gastroenterology Barrett's esophagus clinical guidelines, which were released in April of 2022. In particular, I will bring attention to recommendations in these guidelines that are changes from the previous guidelines published in 2016. Barrett's esophagus is defined as a columnar-lined esophagus at least 1 centimeter in length, with pathology consistent with intestinal metaplasia. The length of the columnar-lined esophagus is determined by the distance between the top of the gastric folds and the squamocolumnar junction, also called the Z-line. In patients with normal anatomy, the top of the gastric folds, the squamocolumnar junction, and the diaphragm are all at the same level. In this diagram to the right, you can see all of these landmarks, but this patient has a long suspected Barrett segment with a hiatal hernia. The spectrum of Barrett's follows a stepwise progression of disease, starting with non-dysplastic Barrett's, progressing to low-grade dysplasia, high-grade dysplasia, and esophageal adenocarcinoma, which can be intramucosal or submucosal. Indefinite for dysplasia is a pathologic diagnosis where the pathologist cannot confirm the presence of or exclude the presence of dysplasia. And this is often seen in patients with active inflammation. So we'll start by discussing the updated recommendations in the new guidelines for Barrett screening and diagnosis, then discuss recommendations for surveillance, and lastly, discuss recommendations for treatment strategies for Barrett's. Identifying and screening individuals at risk for Barrett's esophagus and esophageal adenocarcinoma is extremely important. Patients diagnosed with esophageal adenocarcinoma, concurrent Barrett's is seen in about 60% of patients. If we only look at patients who are diagnosed with early stage esophageal adenocarcinoma, concurrent Barrett's is seen in over 90% of these patients. However, sadly, only 12% of patients who are diagnosed with cancer were previously diagnosed with Barrett's. It's difficult and challenging to identify which individuals are at risk for Barrett's and who we should screen. But data has shown that the prevalence of Barrett's in patients without GERD or without risk factors is extremely low. When you add GERD in, it raises the prevalence to 2.3%. If you add GERD plus a single risk factor, the prevalence increases to 12.2%. And if you add 3 risk factors to a patient who has GERD, then the prevalence of Barrett's is 14.6%. Thus, the guidelines recommend a single screening endoscopy for patients with chronic GERD symptoms and at least 3 additional risk factors for Barrett's based on the data. These risk factors include white race, male sex, age greater than or equal to 50 years old, tobacco use, a BMI greater than 30, or a family history of Barrett's esophagus or esophageal adenocarcinoma. Despite the rising incidence of esophageal cancer that we're seeing, the vast majority of high-risk individuals do not undergo screening. In fact, this was evaluated in 2 different healthcare systems within the past year. And one healthcare system found that their rate of Barrett screening in high-risk individuals was 10%, while the other study found that their rate of screening was 40%. So we have a lot of work to do. Aside from screening with an EGD or an upper endoscopy, possible screening methods also include unsedated transnasal endoscopy. Although this screening test has a sensitivity and specificity over 90 and 95% respectively, it is not readily available at most centers in the US. But newer, less invasive modalities are currently being developed. And the guidelines currently recommend the swallowable non-endoscopic capsule sponge device combined with a biomarker is an acceptable alternative to endoscopy for screening for Barrett's in those with chronic reflux symptoms and other risk factors. So as the field moves forward and towards these non-invasive screening modalities, various testing is being developed. These modalities, the goal is that they can be performed in a PCP's office or even within the comfort of a patient's home without the presence of a healthcare provider. All of these different modalities work similarly in that a patient swallows the device, and then the device is withdrawn orally via a string. And as the device comes up through the esophagus, it scrapes the esophageal mucosa, and then that sample is sent to the lab to look for markers that are found in intestinal metaplasia, whether or not they're protein markers or methylated DNA markers. So this, on this slide, you can see that A represents a device called the cytosponge, B is esophagcap, as well as C is an open esophagcap, and then D and E are lucid EsoCheck. With the establishment of the KDO and Paul M. Rady Esophageal and Gastric Center of Excellence earlier this year, here at the University of Colorado Anschutz Medical Campus, we are really at the forefront of Barrett's esophagus screening, diagnosis, and management. We have a strong multidisciplinary team and have multiple ongoing studies pertaining to Barrett's esophagus. We have 2 studies in particular that pertain to minimally invasive screening modalities. The first is looking at Lucid Diagnostics EsoGuard and EsoCheck and the ability for this device to detect the spectrum of Barrett's disease. So if there are any patients that you know that meet the study criteria listed here, please consider letting them know about the study. The second study that we have ongoing is a pilot study for EnteroTracker, a string-based collection device that captures esophageal and mucosal samples and is currently validated for use in EOE patients. It's currently being modified or been modified for the use in Barrett's esophagus, and hence we are performing this pilot study. This device was actually developed here at the University of Colorado. If you have any patients that meet the study criteria listed here, please consider referring them. So next we'll move on to discuss updated recommendations for the diagnosis of Barrett's esophagus. So guidelines now recommend a 10-step approach to performing a high-quality Barrett's exam. These 10 steps include using a distal attachment cap, identifying esophagogastric landmarks of the diaphragmatic hiatus, the gastroesophageal junction, or the top of the gastric folds, and the squamocolumnar junction, also known as the Z-line. You should also clean well using water and suctioning carefully to avoid traumatizing the esophageal mucosa, using both insufflation and desufflation to identify very subtle lesions. Spending adequate time inspecting the Barrett segment, both in on-FOSS view as well as retroflexion to also inspect the gastric cardia. Using both high-definition white light endoscopy as well as chromoendoscopy to inspect the Barrett segment and identify any concerning lesions. They also recommend using the PROG classification and the Paris classification to describe the Barrett segment length, as well as to describe any lesions to standardize documentation, and to use the Seattle protocol when sampling the suspected Barrett segment to increase diagnosis as well as dysplasia detection. So, as I mentioned, the guidelines recommend that the columnar mucosa of greater than 1 centimeter in length be necessary for the diagnosis of Barrett's esophagus. But also, the guidelines mention that patients with a normal appearing Z-line or squamocolumnar junction should not undergo routine endoscopic biopsies. In the absence of any visible lesions, patients with a Z-line less than 1 centimeter should also not undergo routine endoscopic biopsies. And this second point is really supported by evidence that shows for less than 1 centimeter of a columnar-aligned esophagus, there is extremely low risk of progression to high-grade dysplasia or esophageal adenocarcinoma when biopsies show intestinal metaplasia. And this can be seen on this graph to the right. In addition, these patients who have intestinal metaplasia on their first EGD, when they come back for a follow-up EGD, over 50% of these patients no longer have intestinal metaplasia seen. A study performed in 2020 found that for patients presenting for an EGD with a normal Z-line or an irregular Z-line, over 90% of these patients had biopsies obtained. Over a third of patients with biopsies had intestinal metaplasia, and over 80% of those patients with intestinal metaplasia were recommended surveillance EGDs to be performed. So not only does this practice mislabel a patient as having a precancerous condition, but it leads to unnecessary surveillance procedures that have risks and costs to the patient. So now we'll move on to updates to the guidelines with regards to surveillance of Barrett's. The main updates are within regard to a non-dysplastic Barrett's esophagus. And they state that that non-dysplastic Barrett's esophagus segments should be surveyed according to the length of the segment. So longer segments, or segments greater than or equal to 3 centimeters, should be surveyed every 3 years, while segments that are less than 3 centimeters should be surveyed every 5 years. And this is based on data that shows that segments less than 3 centimeters in length have a much lower rate of progression to high-grade dysplasia or esophageal adenocarcinoma than segments greater than or equal to 3 centimeters. The other recommendation I'd like to highlight with regards to surveillance is the recommendation to use both white light endoscopy and chromoendoscopy in patients undergoing endoscopic surveillance. I mentioned that this is crucial to doing a high quality exam for diagnosis, but the same stands for surveillance exams as well. So chromoendoscopy can be performed with virtual chromoendoscopy like narrowband imaging or eye scan, or it can be performed according to the traditional method of using vital dyes like acetic acid. Chromoendoscopy improves detection of irregular mucosal or vascular patterns, which might harbor dysplasia or carcinoma. Additionally, it's thought to be helpful because the added time of inspecting the Barrett segment gained by adding chromoendoscopy is thought to also help improve detection of lesions. Traditionally, surveillance is recommended by performing 4-quadrant biopsies every 1 to 2 centimeters of the Barrett segment, and this is known as the Seattle protocol, which has been shown to increase detection of high-grade dysplasia and cancer compared to other biopsy methods. However, data has shown that adherence to the Seattle protocol is low, less than 50%, and adherence tends to be lower for longer Barrett segments, which are at higher risk of containing a dysplastic lesion. Thus, other modalities are being assessed, including wide area transepithelial sampling. This is the use of an abrasive brush to sample the Barrett's area and has been compared to the Seattle protocol for surveillance. But the data for Watts as an alternative surveillance strategy is mixed, although Watts has been shown to improve dysplasia detection when used as an adjunctive method for surveillance. We have an ongoing study here that is aimed at helping to elucidate how Watts can be used or should be used for surveillance. And we'll wrap up by talking about management of Barrett's esophagus. So we already discussed that the management of non-dysplastic Barrett's involves surveying these individuals every 3 to 5 years according to their segment length. For Barrett's esophagus with low-grade dysplasia, the updated guidelines now suggest endoscopic therapy to reduce the risk of progression to high-grade dysplasia or esophageal adenocarcinoma. The guidelines state this, but also state that surveillance endoscopy is an acceptable alternative. The management of Barrett's with low-grade dysplasia is a very hot-button topic right now, and there's a lot of controversies about what should be done. But at the end of the day, this should be a patient-based approach in deciding if a patient should undergo surveillance or endoscopic therapies. To better answer this question of what is optimal management for patients with Barrett's with low-grade dysplasia, Dr. Wani has a $10 million grant and is currently enrolling patients for a multi-center study evaluating outcomes in patients with low-grade dysplasia who undergo surveillance compared to those who undergo endoscopic therapy. So endoscopic eradication therapy is the term used for endoscopic treatments for dysplastic Barrett's. The principles of endoscopic eradication therapy, including resecting all visible lesions. This can be done in the majority of cases with endoscopic mucosal resection. In some cases, endoscopic submucosal dissection may be required. The second principle of EET is to ablate the entire Barrett segment. This can be done with radiofrequency ablation or cryotherapy. And patients who undergo EET should be continued to be surveyed and should undergo further EET until the goals of treatment are reached. So the goals of treatment include complete eradication of dysplasia and complete eradication of intestinal metaplasia, or CEIM. So once CEIM is attained, patients should continue to undergo surveillance periodically in order to identify recurrent intestinal metaplasia or recurrent dysplasia so that they might be treated and managed within a timely manner. Cessation of surveillance should be considered for patients who no longer are candidates for endoscopic eradication therapy. So the guidelines also now suggest that patients with Barrett's esophagus undergoing endoscopic eradication therapy be treated at high volume centers. And they define high volume centers as those that have 10 new referrals for high-grade dysplasia or esophageal adenocarcinoma per endoscopist per year. And the reason why they recommend this is because data has shown that patient outcomes are improved for individuals undergoing EET for dysplastic Barrett's at these high volume centers with regard both to attaining goals of eradication therapy as well as adverse events. So to summarize, our take-home points include making sure to screen and identify at-risk individuals. Do not biopsy the columnar esophagus if it is less than 1 centimeter in length. Perform high-quality Barrett's exams. Take your time. Use chromoendoscopy techniques like narrowband imaging. Manage Barrett's with low-grade dysplasia using a patient-centered approach. And consider referral to a high-volume center for endoscopic eradication therapies. So in summary, please join us in improving care for our patients who are at high risk for Barrett's esophagus and those with Barrett's esophagus, so we can decrease the incidence of esophageal adenocarcinoma, as well as decrease the morbidity and mortality associated with this horrible disease. I'd like to thank Sachin Wani and our research assistants, Jasmine, Case, and Jack for their assistance with creating this presentation. And I'd like to thank Dr. Jones and Dr. Kolra for inviting me to speak today. Thanks for your attention.
Thanks, Dr. Pokala, for that amazing and very thorough talk on the latest and greatest advancements for evaluating and managing our patients with Barrett's esophagus. Moving on in session 3, our next topic is going to be from Dr. Hazem Hammad. He's an associate professor of medicine in our advanced therapeutic endoscopy section, and he's going to be giving us a talk on endoscopic management of large and complex colorectal polyps.
Good afternoon, Blake and Avash. I can't be more proud of you guys. Thank you so much for the invitations and for taking on this great conference. And can't thank enough Matt, Lindsay, and Christy for sure for keeping this course going strong. And thank you guys for being here. We know Saturday and everybody's probably had a busy week. We know we did. But before we took too long, let's get on to this talk and talk a little bit about endoscopic resection. We were going to talk a little bit more in general about endoscopic resection, but we all know that we see a lot more colon polyps and more of these lesions. So we'll just keep it to colon polyps today. But if you have any questions later about endoscopic resection in general, we'll be more than happy to discuss these. Okay, so here we have a 70-year-old patient with history of hypertension and chronic kidney disease who underwent a surveillance colonoscopy. There were multiple small polyps that were removed, and a 2-centimeter polyp was found in the rectum, starting from the dentate line, and the biopsies showed high-grade dysplasia. So another repeat colonoscopy showed a similar lesion. It was a large lesion with a slightly depressed center, and the pattern was also concerning for an advanced neoplasia. So what would you do if this was your patient that you're taking care of? Would you consider referring this for EMR? Would you think about a endoscopic submucosal dissection, transanal surgical excision, or referral to surgery given the high-risk features and the high-grade dysplasia for abdominal perineal resection? So what we do, and we will talk about the rationale for this, is endoscopic submucosal dissection for this patient. We will start with marking this lesion to make sure that we have all the lesion and the surrounding tissue with negative margins, and then proceed with a circumferential incision, and then submucosal dissection from the underlying muscle layer, and then remove the lesion en bloc. So when we have and that's what we tell our patients, that but only 50, by the time we remove the lesion, a lot of people think that we're done or we're close to being done. And what I tell my patients is like only about 50% of the job is done, because a lot of the work is done after you remove the lesion and send it to the pathology, because that's when you actually can tell the patient, are they fine, or do they really need more attention or more care, more chemotherapy, more radiation? And so for this patient that we just discussed, there was a 2-centimeter tubular adenoma with high-grade dysplasia. There was a focus of adenocarcinoma. And we don't stop here. We will take it a little further to see what grade of this cancer was. And this was a well-differentiated tumor. There was no lymphovascular or perineural invasion. The tumor invades into the submucosa. That gets us a little concerned. But the extension was only about 190 microns. So we really take a very, very little measuring tool and then go to the microns. A micron, if you guys can imagine the millimeter, is 1 in 1,000 of a millimeter. And these things matter for patient care. So this was about 0.2 of a millimeter extension into the submucosa. The tumor budding score was low. All these are good features. And then the deep and horizontal or mucosal margins were negative. So with that, we can tell the patient that congratulations, this resection that we did was a curative resection with very low risk of recurrence or spread of this early lesion or cancer. So after have talked about all this, what is endoscopic resection? Basically just a minimally invasive technique for excision of superficial GI neoplasia. It is an alternative to a more radical surgical treatment. The only drawback to this kind of treatment that it's a local treatment. We just excise or scoop out the lesion. We cannot harvest lymph nodes to evaluate those. So it would only work for those patients who have negligible risk for lymph node metastasis. So that hence all this like looking into all these criteria to see if this actually a lesion was a low risk for this lymph node mets or not. Okay, so when I talk to the patients about these lesions, we talk about the layers of the GI tract, and most of the GI tract come in 5 layers. As long as the tumor is in the superficial or inner layer, that's the mucosa, or the superficial part of the submucosa, and we can scoop it out completely, then the patient is in, the outcome is very good. If the tumor is going deep into the wall, then it doesn't matter. It's not about the size. It's actually about how deep that tumor is rather. So we can cure anything that goes all the way down to the superficial submucosal layer. And the same thing, the reason with that, because if we take it all the way down to the superficial submucosal layer, the lymph node risk is very, very low. And as we always say, it all starts with seeing. Endoscopic evaluation and identification of these early lesions and deciding which lesion actually has risk for lymph nodes, which lesion does not have that risk, really is very important. This, when you look at this polyp and just, with the white light, that you may not understand a whole lot about it, but when you turn on the different knobs on the scope, what's called enhanced imaging, you can see a lot more and try to identify more about this polyp and also the characteristics, or what we call now visual biopsy. Like you actually can just be like a pathologist. Instead of just looking under the microscope, you're looking with your tools and enhanced imaging tools that are available on all the scopes nowadays to characterize this lesions look like a precancerous polyp, this looks like early cancer, or this looks like a deeply invasive cancer that probably should be handled differently. We talk about Paris classification, and this is just how the lesions look. Is it pedunculated? Is it sessile? Is it slightly depressed? Is it ulcerated or excavated? So you will hear this designation for these lesions. For example, if it's an excavated or ulcerated lesion, the risk of lymph node metastasis is very high, and those lesions should not be treated endoscopically. There's also the characteristic of these lesions with enhanced imaging, like the NICE classification, where we look at type 1, 2, and 3. Type 1 are those hyperplastic polyps. They look pretty plain on imaging with the enhanced tools. If the lesion has more like a brain pattern, huge with a regular pattern, when we see them under the narrowband imaging, those are typically precancerous polyps that could be handled successfully with endoscopic resection. If we look at the lesion and we see part of it has this amorphous or absent pattern, then we start thinking that this lesion actually may be too deep and the risk of lymph node is high and probably should not be handled endoscopically. A lesion like this probably the best course of action, even if it was small, is just to be biopsied and sent for a surgical evaluation. Kudo classification is another more complex, but basically from 1 to 6, 1 being the normal tissue. Again, a really simple way to remember, if you can see regular pattern of this tissue with enhanced imaging, this is fine all the way to Kudo 4. When it becomes irregular, but you can still see the pattern, this is still fine. You can probably resect that endoscopically with a good chance of endoscopic curability. But if you don't see the pattern here, this is probably too advanced, and this lesion should be only biopsied and referred for surgery. A term you would hear quite a bit about is lateral spreading tumor. This is any lesion that is flat or elevated more than 1 centimeter. Non-granular, or those flat, smooth lesions, have more risk for invasive carcinoma than those lumpy, bumpy, or granular type LST that we see. Like it or not, actually, in the last 20 years, this is the graph for the surgery for patients who have colorectal polyps, benign colorectal polyps. The incidence of surgery has almost doubled in the last 20 years for patients who are being referred for surgery for benign colorectal polyps. And this does not come without a price. There's about a 1% 30-day mortality, but 15% major post-op adverse event, also need for about a 5% risk of needing a second major surgery, and also a colostomy. And remember, we're talking about actually a benign polyps here. When we look at also the mortality, particularly when we look at those patients who are really old and have multiple comorbidities, you can see really significant mortality for these colorectal surgeries for these patients. And, most of the patients that we have are in their 60s, 70s, 80s, right, that have these large polyps or that are being, screened and surveyed for colon polyps. When you look at the surgery versus endoscopic resection, major difference. I am yet, thankfully, to remember that we lost any patients doing endoscopic resection on. But if you look at the really surgical mortality, it's very high. So with colorectal EMR, basically, this is, as most of you know, injection of a submucosal lifting agent. And most of the time, we do piecemeal resection of these benign precancerous lesions. The technical success is more than 90%. The concern with that, when you do piecemeal resection, that there is a lot of recurrence. You leave small islands or strips of tissue between these pieces that you remove. In many of the studies, up to 16 or 20% actually. However, even with that concern for this recurrence, most of these recurrences can be handled endoscopically. One new concept that we talk about is this snare tip soft coagulation. Is after removal of these large lesions, you take the tip of the snare and coagulate the edges just like that. And this is a demonstration of that. So this lesion was resected completely. And then after you remove the lesion, you take the snare. And this is good for a lot of the nurses that we have. The same tool. You don't have to have another tool. You're not increasing the expenses of the procedure. And you turn your setting to soft coagulation mode, and then touch up the edges about 5 to 10 millimeter of whitish tissue around. Gentle technique, and that can really decrease your chance of recurrence to about 1%. In randomized trial, in a prospective real-time also prospective cohort, also has been shown to be really decrease that chance of recurrence to 1%. So these techniques work really good. One really important concept that we talk about these days for these lesions that we see quite commonly these days because of the better optics on the scope is the sessile-serrated adenomas. Those are the flat polyps with the mucus cap on them. We see them often in the right side of the cone. When we used to do piecemeal EMR and even more advanced resection for these lesions, nowadays the standard of care is to do piecemeal cold resection for that. Injection under these lesions, and then you remove them with cold snare. This has been shown to be as good as the EMR technique, and also with a lot less chance for bleeding, perforation, and all these issues that come with endoscopic resection. And also the recurrence rate is actually similar to the EMR technique. Cancer in pedunculated polyp is different. It's not the cancer itself, it's how deep into the stalk is what really matters. So when we see a pedunculated polyp, we really are careful where that snare is on the, where do you cut this, because you want to try and make sure that you have a really nice margin on the stalk. And that's what the pathologist will use, because that could mean a difference between a patient needing colectomy or you tell the patient that they're cured. ESD is a more advanced technique that starts with lesion assessment and then marking the lesion, injection of submucosal lifting agent, and then circumferential incision, submucosal dissection under, and then basically you end up with a really large area of resection with an en-bloc removal of this lesion. This will really help pathology assess the lesion much better with the margins, and even if there is a small cancer, that they can really tell you how deep that cancer is. This is an example of a procedure, of an ESD procedure. After submucosal injection, there was starting with a circumferential incision and slowly proceeding with the submucosal dissection. This is the muscle layer here. This is the submucosa with the lifting agent that's stained with the blue color, methylene blue or indigo carmine. Bleeding is not unusual to see. And that's, as we say, just part of the deal. You just have to be ready to deal with this. That it makes a big difference to have a team who is trained to handle these situations and remain calm when you have something like that. Many times we use traction to be able to maneuver around the difficult angles of the cone or the rectum, as was shown there. And then finally, we can resect the whole lesion en bloc. This is about 80% circumferential resection. Usually this heals nicely without any issue. This is an amazing, and it always amazes me how beautiful the human body can heal. I mean, you can't really imagine that this is the healing scar from that massive resection that we did for this patient. She was doing fantastic a year later. Imagine if this patient would have had a partial colectomy, potential for a colostomy, all these things, or change in life and quality. So these things can really matter. We talk about this fancy endoscopic submucosal dissection. It really sounds cool, but is it really right? It's more complex procedure. It takes longer period of time. So what we do is really selective ESD is probably the best and the most cost-effective way to approach these, and only for lesions that have high suspicion for low-risk submucosal invasive cancer. So lesion that looks suspicious but can be cured endoscopically, this is where we really use this technique. This is where you have some irregular pattern, depressed center, size more than 5 centimeter, location in the rectosigmoid, and also remember that the smooth lesions, the smooth polyps, or the lateral spreading tumor, non-granular. ESD is now in the guidelines with ESGE, and for any colorectal non-granular depressed lesion more than 2 centimeter, also with the updated guidelines from ASGE as well as the ESGE as well. So remember those high-risk lesions. So one thing, like if we really come out with this lecture is if we understand and we agree on this, that would be really great, is that lesions without characteristics of deep submucosal invasion should not be referred for surgery without consultation with an expert endoscopist for evaluation of polypectomy, EMR, ESD. You'd be surprised, right? Like that, you're just taking away business from colorectal surgeons and all this. But I tell you that a lot of my work, actually comes from colorectal surgeons, that actually handle these patients and believe that this is a better option for these patients. We're going to talk just a couple of minutes about some of the newer techniques that are out there to handle these difficult colorectal polyps. Endoscopic full thickness resection is a cap that's mounted on the scope where you can actually pull a part of the wall of the colon and then resect it completely. So basically just that part, the whole part of that cone is removed after putting a clip on. This is a patient who was dealing with a difficult polyp that's just that kept recurring, and then finally ended up with a 1.5 centimeter polyp in the cecum, and with the pathology that's showing tubulovillous adenoma with focal high-grade dysplasia. Routine or the standard polypectomy techniques were not possible. We can see this lesion here. Really difficult to do EMR, difficult to do ESD because of the thin wall and because of the scarring from the prior attempts. So that's where really the full thickness resection can be really very valuable. So this is marking of this lesion here. And then this is the device. Our fantastic advanced fellow, Dr. Pokala, would tell you that it looks really easy and make it look easy. But advancing this cap through the cone is not that easy. And sometimes you have to be really careful. It's a big cap, especially with these older patients who have fixed cone angles. We're pulling the whole wall actually of the cone here inside this cap, being careful to not suction too much and pull some of the adjacent structures. For example, in the sigmoid, the ureter just passes by, and actually there have been reports that you can pull the ureter inside. And then we deploy the clip and then cut on top of that. And that's how it looks. We have a full full thickness piece of the cone with actually some ammental fat on the back. So we got the whole thing. And the pathology usually just shows you this full thickness resection. One of the newer kids on the block is Endorotor EMR. This is a non-thermal mucosal resection device that's basically a catheter with suction and a blade, a rotational blade that can basically shave off the scarred lesions. This is the device here. There's a suction from inside, and then the blade goes inside this. You suction part of the lesion, and then the blade basically shave off the lesion. This also works really good for these very scarred lesions that are low risk, and you just basically really hate to send these patients for surgery, but they just keep having these recurrences or residual of this this polyp. This is one really good way to handle that. It's a tedious process. You really have to be careful because sometimes if you're not careful, you can actually suction the muscle layer and end up with perforation using this tool. So you have to be careful where that suction is applied. But when it's applied in the right way, it works really, really good. You'll see the end result here. So this is the end result, really looks good, clipping after. And then just for some tips for endoscopic resection, we always advise to use cap. That's the distal attachment cap on the scope when possible. To use some staining method for the submucosa using methylene blue or indigo carmine. To use stiff snare, even in the community setting, if you're embarking into doing endoscopic resection, really you need to get some stiff snares for these procedures. Don't forget about this really neat technique called snare tip soft coagulation to decrease your recurrence of polyps. And then also do not forget about the cold snare EMR technique for cess-ulcerated adenomas. Thank you very much.
All right, thank you, Dr. Hammad. And our last and final talk for this session, actually our last and final didactic talk for the day, is going to be courtesy of Dr. Stephen Edmundowicz, who is currently the interim division director for the Division of Gastroenterology and Hepatology, and also the director of the Digestive Health Center. He's going to be giving us a talk on the endoscopic management of complex biliary obstructions, art of the trade.
"43 days, but no one's counting." Good afternoon. It's really nice to be here. I've shortened my talk because I knew I was following Dr. Hammad. So we'll see if we can move forward. These are my objectives. I just want to talk a little bit about the management of obstructive biliary disease, primarily talking about the clinical aspects of it. My disclosures for the lecture are listed there as well. So when we think about biliary obstruction, there are really two common categories we run into. There's stone disease and malignancies or strictures. And when your patients present, they typically can present with a history that you want to dive into a little bit to make sure that you're not missing something like they had a gallbladder operation that was complicated, or they have a strong family history of pancreatic cancer, or these kind of things. They typically present yellow. And the way I kind of think about it is if they present with painless jaundice, I'm very worried about a malignancy, because that's typically how patients with pancreatic cancer and biliary cancers present. If they present with pain, like colicky pain, I'm thinking more stone disease. And I'm thinking maybe this patient has retained bile duct stone or has had complicated cholecystitis. They'll all have obstructive liver enzymes, just no matter which the etiology is. Typically, alk-phos, bili, and GGT will be elevated in addition to the bilirubin. And the one thing that's kind of interesting is you want to think about cholangitis in these people that present kind of with achy pain or just low-grade fevers. And I've learned recently that screening these patients is surprising. I had a patient walk into the lab to get some blood work because he was having symptoms. I said, I'm just going to, out of curiosity, I'm just going to send some inflammatory labs and see what's going on. And sure enough, they were markedly elevated. And this patient got admitted, got treated with antibiotics and IV fluids very quickly, and I could have easily dismissed that on the phone. So it was kind of an interesting situation. The two comments I'm going to make. One is CA19-9 is a very nice tumor marker for pancreatic masses. It goes very high. It's extremely elevated in cholangitis and biliary obstruction. So please don't tell the patients that they have a cancer when you have a CA19-9 of 10,000, but they actually have cholangitis. The second thing is that biliary obstruction, as I'm presenting it, is great, but you want to see obstruction somewhere. So either an ultrasound, a CT, or an MRI should show that there's dilation of the biliary tree. Occasionally, we see early cases where there's no dilation, but for the most part, you'll see this. So this is the stone side of the talk. You can all identify that this is our typical ERCP scope. And the scope is actually in position in the duodenum, dilated bile duct. And here you see the filling defects as we put contrast into the biliary tree. Those can be obstructing. They can stick in the bottom of the duct and actually completely obstruct it. You can move them usually freely with the scope. And these are the tools we use to manage them. We open the sphincter with a sphinctertome, and then we either use a basket or a balloon to pull these stones out, and that typically relieves the obstruction. We do this routinely on an outpatient basis, and patients are quite satisfied when they're done. Another example, same thing, stone in the biliary tree at the bottom, stone in the balloon above it. You do the sphincterotomy to open the sphincter, and you sweep the stones out. Everybody in the state, I think, that does ERCP is doing this on a regular basis. The bilirubin and the liver enzymes should resolve fairly quickly, and everyone should be happy at the end of the day. This is a interesting video. I'm going to show you the sphincterotomy. It's from a friend of mine. Nice big sphincterotomy and a big papilla. This is how we cut with the cutting wire. He then puts a balloon into the distal bile duct because this patient has big stones, as you saw on the cholangiogram. This is the balloon dilation that we do up to 15, sometimes 18 millimeters. And then the same tools we use to take the small stones out, we basically put up into the biliary tree. This is all the view from the ERCP scope, and we pull the stones into the duodenum and let them pass. And that technique can be very useful. You can actually remove fairly large stones. This is not a new modification because this is a stone I took out in 2001, 201, so 23 years ago. So it is possible to take big stones out of the biliary tree without surgery and relieve obstructions. We have some additional tools that are kind of interesting. They've kind of evolved over the years. We have a mechanical lithotripter, which is kind of like a nutcracker. It essentially has a basket and a long steel sheath. You put this steel sheath through the scope into the biliary tree. The basket's now deformed because we cracked the stone that had the density of granite into multiple pieces, and then you pull it out. And these are used for big stones that you just can't pull out with balloon dilation. The thing that's really revolutionized our work in the biliary tree is this single operator cholangioscope. It's a second scope that we pass inside the ERCP scope, pass it up into the biliary tree. You can see big stones. You can actually see the structures nicely, and you can use laser or electrohydraulic lithotripsy to break up the stones. Electrohydraulic lithotripsy is basically spark gap technology. You have a catheter that's on the end of the steel tip at the end of a catheter that generates an electrical spark that creates a shock wave in the bile duct, and it fragments the stones. It actually works pretty well. I think this is going to play. So this is the choledocoscope looking in the biliary tree. There's a quite large stone that was not easily to be entrapped in a basket or balloon. That's the EHL probe at the bottom, and with one shot, it starts to fragment. Some of these stones are like sand clusters. They break up very easily. Others are like chips of granite. They're very hard to break up. But once we reduce the size of the stone to a size that we can extract into the duodenum, we can then go with our tools and pull all the pieces out, relieve the biliary obstruction. And again, these patients can be done as an outpatient, and this should recover fairly quickly. Now, all of this is not without the risks of ERCP, i.e. pancreatitis and bleeding and cholangitis, but for the most part, it's a pretty standard standard procedure. And I think in our group schedule, if we see a stone case, everyone starts smiling because it's a lot easier than the other cases that we're going to talk about that we end up dealing with here. I just want to show this for a second because, oops, I'm sorry, I interrupted that. The stone looks like it's been completely fragmented now. The pieces look like they're at least half the size of the bile duct. And then using the balloon or the basket, we can then pull these pieces out into the duodenum, just like we did the single stone. And you can actually clear quite a large stone burden with these techniques. We can do the same thing with lasers. They're a little more efficient, a little more expensive, but they actually are very effective at breaking up the stones as well. And the last pre-surgical attempt we have for breaking up big stones is the same shockwave lithotripsor that you use for kidney stones can be applied to the biliary tree and the pancreas to break up stones as well. This was popular back in my era. Hasn't been used very often now that we have cholangioscopes and other tools that are more fun to play with than these machines. And I wanted to show this. Sometimes you get lucky, and when you go to do your procedure, you find the stone is actually stuck in the opening trying to get out. And this is a good demonstration not only of how you can open up the papilla to allow the stone to pass into the duodenum, but what actually happens in the physiology of cholangitis. So this patient presented with cholangitis, had a bilirubin of about 13, had high white count, had almost septic parameters, got fluids, IV antibiotics, and was brought to the endoscopy suite. And as my fellow is actually incising the papilla here, opening this up, you start to see the pressure that the bile and the infected material is under coming out. And you can understand how this could actually translocate to the portal system and cause sepsis because there's really a lot of pressure in the system. The stone falls out, and even after the stone's gone, without any negative pressure in the duodenum, it's just flooding the whole duodenum with bile and pus. So it's a very rewarding procedure when you can accomplish this. The patients actually often feel better by the time they're leaving the endoscopy suite. So I want to talk about the other half of biliary obstruction, and that is the stricture side of it. A little more complicated and a little more complex. Strictures can occur anywhere in the biliary tree. This is a nice review of the anatomy, starting down at the papilla and the sphincter of Oddi here, the common bile duct, cystic duct coming off, common hepatic duct or main duct, then the bifurcation, right system, left system, as we look at it in the ERCP films. This is demonstrating that strictures can occur anywhere in that biliary tree. In certain conditions like PSC, you'll have strictures everywhere. In other conditions, you'll have dominant strictures that are causing the obstruction. And as you can imagine, your imaging, your three-dimensional imaging, which is extremely helpful in managing these patients, will tell you where the stricture is by where the ducts are dilated and where they're not. So when I get referred to stone case and the only thing we see on the MRCP are dilated ducts above the bifurcation, I get very nervous because that's typically a Klatskin tumor or something involving the bifurcation that's going to be very complicated. Whereas if I see dilation all the way down to the papilla, I'm pretty happy because I know that's going to be a pretty straightforward case with something down in the distal bile duct. So location is key. The extent, you can have multiple strictures. The severity is kind of interesting. You don't really appreciate that until you're doing the procedure of how tight the stricture is. And the compliance of the stricture can be a real problem. The most challenging strictures, these post-op ischemic strictures with clips all around them that are almost like rock. Very hard to get stuff through there and to dilate them, but it is possible, and we have a number of tools that I'll explain to do that. The location for us is very useful. If it's right around the ampulla, it can make cannulation a little challenging, but if it's up a little bit, the typical pancreatic cancer stricture, those are usually pretty straightforward because you have good access, you're close to the scope, so you can push things through the stricture and you can deal with it. Any of my colleagues want to tell me what this is? Right, it's a double duct sign. It's a double duct sign in malignant pancreatic cancer. Cancer's right here, blocking both the pancreatic duct and the bile duct. But as you can see, the distal bile duct is actually normal. So I should be able to cannulate, get a wire in here, push it up above to the dilated main duct and then the bifurcation, and put a simple stent in, do brushings and biopsies, make a diagnosis. So this is what we typically see in pancreatic cancer, and those are the strictures that are probably the easiest to deal with because they're away from the papilla, but they're in the region of the duct where you're not going to have much trouble pushing things through. What about the bifurcation and beyond? Well, that creates a little more of a problem because you're further away from the scope. You're up here now. Your tools are a little bit flimsy. They're plastic or they have a steel wire in them, but you have to push above that. And then you also have to worry about all these other branches up here that you're possibly going to occlude if you put a stent or a balloon or any other device up there, because it's going to be like a broccoli stalk, right? There's all these branches coming off, and that becomes a little more challenging. So for bifurcation strictures above the head of the pancreas, it's really helpful to have three-dimensional imaging before you start your work. MRCP is an ideal way to visualize this. You can do an MRCP even without contrast. They can do a T2 weighted image, and you can get a very nice picture just like this one here that shows you that this is not just a simple stricture of the bile duct, but it's a complicated stricture involving aspects of the left and right duct. And then when we go to deal with these, we're often not dealing with just one stricture, but we're dealing with right and left main duct strictures. And in this case situation, there's probably other areas of the right ducts that aren't even being filled that are undrained. And for the most part, these are the cases that you really worry about, because if we're not completely decompressing this and we're putting a lot of dye up there, these patients are going to get cholangitis and it's going to be an issue. So we want to approach those carefully, and we always try to approach them with three-dimensional imaging. Now, this is an example of our PSC case. You can see this patient has a dominant stricture in the head of the pancreas, but also a very irregular bile duct throughout the liver. There's areas up here where there's strictures, and there's not much dilation above stream, probably because of cirrhosis. The left side of the liver looks nicely dilated here. This is typically what you'll encounter, and often we can deal with these just by dilating the strictures and cleaning out the debris in the biliary tree. So what tools do we use? Very similar to esophageal dilation. We have passage dilators or straight dilators, savory dilators. We have balloons. And then we do use these stent retrievers that have like a rotary screw on the end of them to sometimes screw our way through these tight strictures to get to where we need to be. We use stents to keep the strictures open. There's a lot of advantages to plastic stents. They're effective, they're low cost. They can be removed and replaced if we don't like where they are. They're widely available, but they also have problems in that the size of the stent is limited to the operating channel of the scope, so nothing more than 4 millimeters. And then the stent occlusion occurs quickly with the plastic stents, sometimes because of biofilm, so we often have to change them out every 2 months or so. And there's a potential for side branch or cystic duct obstruction. This is just some pictures of different stents. They're really like straws with slits on them to hold them in place, where they have pigtails. Some of these are pancreatic stents that have side holes, or biliary stents that have bigger side holes. There's lots of discussion about which is the best stent. Honestly, they all work quite well, and you can always put multiple stents in if you want to have more than one drainage site for the patient. What's changed the practice over the last 2 decades has been these expandable metal stents. Just like in coronary angioplasty, these stents go over a catheter, they expand. They have like a wire mesh that allows bile to drain through them. And now we have fully and partially covered stents that have like a saran wrap coating, so they can't get ingrowth of epithelial cells or tissue. You pass that stent into a strictured area in the biliary tree here, and let it expand after you release it, and it pushes everything out of the way, and you usually get pretty good flow. Because these are so big, 10 millimeters, 8 millimeters are the typical size we use. We tend not to see obstruction of these stents early. So often in our practice, we'll bring patients in who are going to go through a course of chemotherapy and put a metal stent in, so we know they're not going to get cholangitis and sepsis while they're immunocompromised. Larger diameter, longer patency, and the radial forces dilate the strictures. The disadvantage of them is the cost, not a factor for you or me, but in reality, it does increase healthcare costs all over. Uncovered stents can be removed, but it's quite difficult. So if they've been in for a while, it's a little technique change to take them out. And the epithelial hyperplasia is really the bile duct lining that grows into the stent, is often what obstructs these over 3 months or 6 months. And we'll have to put either a covered stent inside or replace the stent. And just a comparison of the 2 different types of stents we use. Honestly, I think all the stents work quite well, and we just are very careful about which one we select based on the patient anatomy and whether we're worried about things like migration or ingrowth. I talked a little bit about the role of MRCP for planning before you do these complicated strictures. I think it's really essential, and I think you can tell when you have a good MRCP because you should be able to see the biliary tree in total. You should be able to see where the strictures are and what you want to approach. You want to plan an approach for these patients with complicated strictures to decompress as much of the liver as you can. It's harder to decompress both sides of the liver at the same time with metal stents or even with any stents. If you can drain a component of the liver that's fairly large, in this case, the right side of the liver, you could easily drain that with one stent. You could probably drain the left side with one stent. Looks like there might be even more liver on the left side than the right. You see as the typical sign I was talking about, the bile duct's not dilated at all. That should be the first warning that there's something going on at the bifurcation. So we review these and decide how we're going to place the stents. One on the left, one on the right. Should we try to put two in? Then we go ahead and proceed. At the time of the ERCP, we're really careful, as I mentioned, not to put contrast out into the whole liver, because then you've got areas that you're going to have to drain and you may not be able to get them all drained at one time. Often we'll collaborate with our radiology colleagues. If there's a segment that's completely cut off, they'll be able to image that with ultrasound, and they can put a percutaneous drain in an area that we can't get to. I use air cholangiograms and other techniques to really visualize what's going on. In the bifurcation, we put plastic stents in, but we can also put uncovered metal stents or covered metal stents, depending on what we're going to occlude. This is an example of just side-by-side uncovered metal stents going up into the liver, draining both sides. And occasionally, if we are kind of having difficulty getting two stents side by side, we can put a stent through one stent into the other side of the liver and drain them as well. So that's basically an overview of biliary obstruction 101 for everybody here. And it was really nice to talk to you today. I'll have time to answer questions during the question and answer period. Thank you for your attention.
All right, so I'll invite all of our discussants back up to the stage. So just as before, we welcome audience questions. We have a microphone up there, and I think Lindsay will go and grab it. So if you're out there and you have any questions, please feel free to raise your hand or stand up. We also, again, have audience response questions just to get the show started. So first question, while people are thinking of their own questions for the discussants, for which of the following should biopsies be obtained from the columnar lined esophagus to assess for Barrett's esophagus?
All right, so this goes over when we discussed when should biopsies be obtained. And so we discussed that biopsies should be obtained from the columnar lined esophagus when it is greater than 1 centimeter or at least 1 centimeter in length. And so the pictures are a little small on the screen, but actually there's two correct responses here. You all did a great job in identifying one of them being C, but B also has a columnar lined esophagus greater than 1 centimeter in size. A represents a normal Z line, so I'm glad that no one picked A. And D represents an irregular Z line, so a columnar lined esophagus less than 1 centimeter in size. So I'm also glad that no one picked D.
Great. Next question. Seems like it's for Dr. Hammad. Endoscopic submucosal dissection is a recommended first-line therapy for which of the following? Superficial lesion in the esophagus, 15 millimeter sessile polyp adjacent to the appendiceal orifice, a colorectal non-granular depressed lesion greater than 20 millimeters, or any lesion in the duodenum.
You all passed then. I think it's this is fantastic. Yes, I think to understand like what is non-granular and depressed lesion means and the risk of neoplasia is very important, and this is the right answer. Great job, everybody.
All right. True or false? Surgical resection of a large polyp with superficially invasive cancer is associated with lower mortality than an endoscopic attempt at resection.
This is again, I think if we you guys may think that this is just a given or that we all know it, everybody should know it, but that's actually not there. Like it's still as I showed in one of the slides, that many patients are still undergoing surgical resection of benign polyps in Denver and around and all over the place. So this is a knowledge that you have to spread. Great job, guys.
All right. And compared to plastic stents, self-expanding metallic stents, they have a shorter diameter, have a longer patency, are cheaper, or are more widely available.
Yep, I think you all got it.
Straightforward. And then, which of the following imaging studies is recommended for planning purposes prior to endoscopic attempt at stenting a bifurcation tumor?
Again, I think that's perfect. You can get good visualization with CT scanning, so I don't want to frustrate you if you've done a really high quality CT and you can see that it's a Klatskin 2 or 3 tumor. By that, I mean at the bifurcation extending or up into the liver, but MRCP really gives you that detail of differentiating those Klatskin 2s from 3s from 4s. So I think that's why it's more useful.
All right. And what is the best next step? This is a case-based question, so I'll read it. 55-year-old female underwent a screening colonoscopy. She is found to have a 5-centimeter rectal polypoid lesion starting at the dentate line and involving 60% of the rectal circumference. Pathology shows a tubulovillous adenoma with focal high-grade dysplasia. What is the best next step?
Whoever is saying surgery has to come out here because I know who it is. but anyway, this is fantastic, guys. Again, it's really not the size. It's not really, most of the time, it's not the location. If we see a benign polyp, there's no invasive cancer on biopsies. This is definitely a case that should be reviewed for EMR or ESD. Great job. Except 2 people.
Another case, 78-year-old male with a past medical history of hypertension, diabetes, underwent surveillance colonoscopy, found to have a 5-centimeter, 6-centimeter cecal-based sessile polypoid lesion in the cecum. Histopathology shows TVA, focal high-grade dysplasia again. What is the best next step for this patient?
I wanted to bring this because it's still to date that we have patients who come and say, oh, this is because I have a polyp in the cecum and this, is really a very complex place and should not be handled. But again, in the availability, if the expertise is available, any lesions in the colon should be, with no deeply invasive cancer, can be handled with endoscopic resection if the expertise is available, like we said. So cecum is okay. The size being large is okay. High-grade dysplasia is okay. So great job, everybody.
All right. That's all the prepared questions we have. And if there's none from the audience, I think that means everyone's eager to get to the next portion of today's session, which is the rooftop soiree, cocktails and everything like that. Before you all run up there, a few last minute housekeeping points. Just want to remind you to submit your tickets to Lindsay or Matt or Christy around here so you can claim the potential $100 prize. You have to be here for the end of the session at 3:30 and give them your cards by 2:45. We're going to resume at 2:45 sharp. Where you can all get to come and watch Dr. Patel kick my butt in a debate about colorectal cancer screening. And then finally, again, want to great shout out and thank you to our talkers for this session, Dr. Edmundowicz, Dr. Pokala, and Dr. Hammad. Thank you so much. We'll see you guys upstairs.